The broadcast is now starting. All attendees are in listen-only mode.
Well, good afternoon, everyone. This is Angie Lockwood, and I am with the FLEX program at the Center for Rural Health at the University of North Dakota. And I see we've got about 50 people registered for this webinar today, and I see some are still coming on. So I'll just do a little bit of the kind of welcome intro info, and we'll try to get started right on time here today. So we see lots of familiar names from our critical access facilities, and that's great to see you all on. Then we also have some folks from tertiary facilities, and welcome to you too. It's fun to see you join as well. Just a little bit of brief background about how these webinars kind of came about. We've got our FLEX program has offered 2 of them this month. So the FLEX program, for those of you that might not be as familiar with it, is the mission is to assist cause critical access hospitals and improve access to health care in rural communities. So FLEX does really have a CAW focus. Over the last several years, one of the things that our North Dakota FLEX program has been able to do, we've done it for many, many years, one activity is to make subcontract funding available through a competitive RFP process for various financial and operational improvement activities to the critical access hospitals in our state. One of those activities being chart audit reviews. So we get lots of applications from our hospitals. Unfortunately, we don't have enough money to award funding to all of our applicants. Our CAWs continue to tell us, once they go through the project, how valuable and educational the chart audits are, and just really that it was meaningful to them and a great learning opportunity for their staff. So this year we had a little bit of extra funding left at the end of the year, and we asked Ed Bailey to present a CAW-focused chart audit overview webinars for us. So on the 14th, on the 14th of August, Sue Rail provided one, and then we have got Rhonda Quast here today. So we are very thankful for them to join us and present it, help out support this effort. So for those on the webinar today, education credits are available for people that participate in the live session today, and you can request those credits at the end of the webinar. In about an hour, I'll put the link up to that, and it's a brief evaluation of the session, and then you'll let us know which type of credits you're looking for. And there is also a link you can click on a button to let us know. FLEX is going to have at least one more coding opportunity in this FLEX grant cycle, and so if you'd like information about that when it comes up, you can complete that button on the Qualtrics survey link. Let's see, what else do we have? We are recording this session, so the links are going to be available on our website. Sue's August 14th webinar session link is available on our website. I can put that website in the chat if you've got anyone looking for that. And at the end of the hour, we are going to open up time for questions and answers. And we decided for this webinar that our questions could be anonymous. Sometimes that feels a little bit safer to just ask anonymous questions. So that's kind of the way we're going to do that. So if you see on your webinar dashboard, you can put questions into the question area there, and I'll just read it, and I don't have to identify the question asker or anything, and we can ask Rhonda if you've got questions that way. You can also, if a question comes up during the presentation, put it in the question area there, and that way we won't forget about it and we can get to it at the end of the webinar. Since we do have so many folks online, and there does get to be a lot of background and interference noise, we have decided, our participants asked us, can we keep it muted, so just to prevent any of that audio interference. So if you've got a question, think of it as it comes up, stick it in that chat, and we'll have anonymous questions today. And Rhonda had said she would stay on and after the end of our time and answer questions from those that have them. So I think, let me see, I think that's all I've got to share with you today. I'm going to hand the presentation over to Rhonda and get to what you came for. So thanks for joining us, and I'll pass it over to you now, Rhonda.
Perfect. Thank you, Angela. So just to give you guys a little bit of background on, what brought me here today, and how grateful I am to have this opportunity. It's interesting as you're always asked to provide background when doing webinars and such like this. And I've realized over the years that the more I have to say in my biography, the older I feel. So, but the more credibility it gives. So just to give you guys a little bit of background for myself, I started in the healthcare industry as a nurse and moved into revenue cycle about 7 years ago. So that doesn't sound as bad if let's focus on the last 7 years. Through revenue cycle, I've had opportunity to be part of scheduling, registration, DNFB reduction, EHR implementations, and now we're learning more and more about HCC scoring. So that's what we're going to talk about today. And really not only what is HCC scoring, but how do you operationalize it? Ooh, this is going to start out rough. In your facilities and in your organization. So we've had opportunity to work with organizations to help them, and learning from that experience, want to bring it to all of you as well. So these are our objectives for today, but really, like I said, want to define what HCC scoring is, or in the long terminology, it's hierarchical condition categories. I won't say that often because no one likes to hear that often. But again, let's talk about why they're important. Why should this be a focus for your organization? Where does this impact you? Common errors that we have seen as we've assisted organizations with this. And then again, like I said, how do you put this into practice in your organization? So let's talk about kind of where HCC scores began. HCC scores started off in 2004. This is a program that CMS has been using for 13 years. And they started utilizing them for the Medicare Advantage plans. So it became quite obvious quickly that Medicare Advantage plans, because they were provided a per member per month payment, it was to their advantage to only take care of healthy patients, because then they weren't having to pay out as much of that per member per month payment that they were receiving from Medicare. So CMS put together this CMS HCC model. And what this did is it allows CMS to understand the risk and expected resource use of a patient, and so how much resource and cost that patient's going to need to take care of them, and then they would adjust that per member per month payment to the Medicare Advantage plan. Well, what we're seeing is CMS really likes this program. They're utilizing it more and more in the value-based programs that are being provided and are starting for our new world in healthcare. So there's an increased emphasis on HCC scoring for all of us, honestly. So what is an HCC score? Let's talk about that first. So an HCC score is determined by multiple different components. And most of these we have very little control. I'm going to say very little, and I always say this tongue-in-cheek now because I gave a presentation similar to this to physicians, and I got to the first one and it said gender, and I had a physician raise his hand and say, that can change. And I thought, oh gosh, so I'm going to say very little now, not no control. But a patient's gender is something that CMS looks at to determine the resource use expected for that patient. Their reason for enrollment, are they disabled? Did they age into Medicare? That impacts their HCC score. Their age, as a patient ages, we expect increased cost utilization from them. If they're dual eligible, so are they on Medicaid and Medicare? That's where your screening programs, your upfront screening programs can become important as well, not only for this, but mainly for your patients too, and your facility. Does the patient live in a community or an institution? But here's the big one that we're going to talk a lot about today. Here's the big area that you in an organization can communicate to CMS the resource use expected for a patient, and that's through your diagnosis coding. This is how CMS is going to know how much resource use that patient is going to need for a year. Okay? Now I want to say right from the beginning, we're not advocating for upcoding, we're not advocating for fraudulent coding, we're advocating for compliant coding and documentation that fully encompasses the condition of the patient, okay? So because CMS, likes to make things a little more complex, not only do we have those different pieces that all fall into an HCC score, but they also took all the diagnosis codes and they broke them into categories, okay? There's 79 categories, and what these categories are is, think of them like buckets. And those buckets are clinically related disease diagnoses that have similar expected cost and resource use. So these are buckets based on, they're all going to be clinically related, but it is not every ICD-10 code. In fact, only about 8,500 are HCC scores, have HCC scores associated with them. And as many of you who are coders on the phone today know, there's a lot more than 8,500, about 10 times more. So, it's a very select few, and that's where that coding to highest specificity really falls into place. So we have the 79 categories, and here's some examples. I'm going to talk a lot in examples today because that's, to me, I like to think in that world, so bear with me. But as we look at the categories, we have category 17. That's all of the diagnoses that are associated with diabetes with acute complications. 18 is going to be diabetes with chronic complications. 19 is going to be diabetes without complications. So you can see the different categories. Now, so we have the 79 categories, but then CMS, what they did is they built in hierarchies. So what these hierarchies do is they say that there are certain categories that will override other categories if the patient has disease diagnoses submitted in the year in both, okay? So an example of that again, let's say a patient has within the year, anytime within the year, we've submitted E119, type 2 diabetes without complications, which is a category 19. And then we've submitted E0821, which is diabetes due to underlying condition with diabetic neuropathy, 18. And then the patient, and again, anytime in the year, these can override each other, we have an E0811, which is diabetes due to underlying condition with ketoacidosis with coma. Now, if all three of these have been submitted in the year, CMS is going to take the higher category of them, the higher weighted category, which is HCC 17, and it's going to remove the score for 18 and 19. That's how those hierarchies work. And that's all done behind the scenes. It's nothing you need to do on your claims. So again, we got the categories, we've got the hierarchies, and then we have disease interactions. So what the disease interactions are is these are used, CMS has recognized that for some patients who have chronic conditions and an acute condition, many times there's resource use associated with the conditions themselves, but also because that patient has both of them, there's an additional resource use utilized. So this is an additional score for a patient having both conditions. Now again, both of them do not have to be on the same claim, but they have to be submitted in the same year, okay? They also have this same disease interaction for some codes that also for disabled patients because they recognize, again, there's an increased resource use for disabled patients with some illnesses. So some examples, if a patient had I-110, hypertensive heart disease with heart failure, there would be an HCC score or a weight of 0.323. And if that patient had chronic kidney disease, stage 4 or N184, there would be a weight for that of 0.237. Now, because the patient has also those together, there's an additional weight added on of 0.27. And the same is true if a patient is disabled and they have a pressure ulcer, you're going to have an additional score added on outside of what you already received for the pressure ulcer. So as you think of HCC scoring, there are some service locations that claims are submitted from that are accepted for an HCC score. This is not an all-inclusive list, but just to let you know, rural health clinics, FQHCs, freestanding clinics, provider-based clinics, critical access hospitals, short-term hospitals, long-term hospitals, claims from those facilities, the diagnosis codes are utilized to build the HCC score. Some areas that are non-covered: swing beds, skilled nursing facilities, freestanding ambulatory surgery centers, hospice and home health care, freestanding renal dialysis, and some of the services that people kind of are taken aback by is lab and radiology claims. The diagnoses on a lab and radiology claim are considered presumptive, so CMS does not utilize those to build the HCC score for a patient. Again, this is not an all-inclusive list, but just to give you an idea, there are certain providers that, when billed under their NPI, that CMS will utilize those claims to build the HCC score, and you'll see it's a pretty extensive list. And like I said, it's not all-inclusive at this point, but just to give you an idea. But this is one important piece that I'm going to spend a little time on here, and it's called the clean slate. So you heard me say a couple times already during the year, through the year, this is because on January 1st, according to CMS, every single Medicare patient begins the year completely cured. So if they had an amputation, if you do not code that they had an amputation or have a history of an amputation or prior amputation during the year, according to CMS, that limb grew back. That patient can be diagnosed with diabetes on December 31st, and it can be submitted on the claim on December 31st. But January 1st of the next year, that patient is no longer diabetic until you document it, code it, and that claim is accepted and paid. Okay, so it's very important to understand this. We know that about 75% of chronic diagnoses are not documented and coded past the year of diagnosis. So we're missing a lot of opportunity to communicate to CMS the care that our patients need and how chronically ill they are, which helps them understand the resources that we need in place in our organizations to care for them. So that was a lot of information in just a few minutes, so let's look through an example. Again, I apologize, this is kind of how I think best, so I'm going to assume all of you do as well. So again, this is a completely fictitious patient. It is made up. One of my coders and I made this up. But as we look at this, we look at the note on top, this is what we would be looking for from a documentation standpoint. So a 72-year-old male residing in a nursing home presents to your emergency room feeling short of breath. Complains of dyspnea, fatigue, and persistent coughing. Recently completed antibiotics for a UTI. A UA done today is clear. Patient appears frail with mild malnutrition, previously diagnosed with COPD, stable on Flovent daily, and that stable is important. Patient continues to smoke. After radiological exam, patient diagnosed with aspiration pneumonia and sepsis. Antibiotic prescribed twice daily for next 7 days. We've got our treatment plan, and we're ready to go. Now, we've got some coding examples on the bottom here, but I want to take a moment. These examples do not affect your reimbursement on the claim, except for the PPS hospitals because of a DRG. If this was an inpatient or a DRG situation, when we look at claims submitted with any of these examples, they would most likely be reimbursed at the exact same amount. Okay? HCC coding and scoring does not affect your reimbursement on a specific claim. But let's walk through what it does affect. So let's look at the poor coding example. We have the 72-year-old institutionalized male. and that has an HCC score of 1.323, and you'll see that's consistent across all three examples. That is those pieces that we have very little control over: the gender, place of residence, reason for enrollment, things of that nature. In the poor coding example, this has been coded as pneumonia, J18.9, which unfortunately does not have an HCC score. So that patient's total HCC score, according to this claim, is 1.323. Or, in dollars and cents, you have told CMS from this claim that it will take about $12,000 to care for this patient for the year. Let's flip over to the complete coding example. And again, all of these have been supported in the note, in the documentation. So again, we have the 72-year-old institutionalized male, that's consistent. But now this has been coded at aspiration pneumonia, J690. That does have an HCC score. It's 0.067. COPD does as well. Tobacco use does not have an HCC score, but it's still relevant to what's going on with this patient, so we would want to include it. And this one always kind of throws people off. Why would tobacco use not have an HCC score? And what CMS has said is that the tobacco use itself doesn't cause increased cost for a patient. It's the diseases that it causes. So sepsis, again, has a HCC score as well as the mild malnutrition. And then here we get into those disease interactions. So because this patient has COPD and aspiration pneumonia, an additional HCC score of 0.254 has been added, as well as for the sepsis and aspiration pneumonia, an additional 0.321. So this claim shows an HCC score of 2.876. Or again, in dollars and cents, you have told CMS it takes over $26,000 to care for this patient for the year. Now, as we think of many of our programs, so any of you who reported for PQRS, you maybe got QRUR reports and you looked at it and CMS started talking about how costly your patients are and how much resource, how high you are in the cost of the care you give. When you look at a patient, if you submitted claims for this patient for the year in Medicare allowed dollars, that totaled $20,000, but if you only submitted the claim for the poor coding example, you're going to look to CMS to be $8,000 inefficient in your care. Again, on the flip side, if you have submitted $20,000 in Medicare allowed charges for the year and you've told CMS the complete coding example where it takes over $26,000, you are efficient by $6,000 in your care for this patient. That's where that cost calculation comes in many of our value-based programs. So let's talk about those programs. What are the programs right now that utilize HCC scoring? Any of you that are in an ACO and a Medicare Shared Savings Program, HCC scoring is utilized to determine your benchmarks. Your benchmarks are all risk adjusted by the complexity of care your patients need, and that affects your shared savings and loss calculation. Okay? Medicare Advantage plans. Again, the higher your HCC score, we've actually talked to Medicare Advantage plans, and they have organizations coming to them because they know they have a high HCC score, and they're able to use that in contract negotiations to get a higher contract determined, a higher payment out of the contract. So not only do the Medicare Advantage plans get a higher per member per month payment, you as an organization can utilize that for contract negotiations, so you do as well. And then CPC Plus, that's a new program coming to North Dakota. The applications closed in May. That'll be starting January 1st, 2018. And this is a direct correlation to HCC scores. So there's different tiers built, and based on where your patients fall, who are attributed to you in those tiers, you're going to get a per member per month payment for each one of those beneficiaries. So again, helping CMS understand the complexity of care of those patients is important. And then MACRA. So ready or not, we all are influenced by MACRA in one way or another. We're all kind of in it, whether we want to be or not. Even if you're exempt, there's other organizations near you that are part of it. So understand that HCC scores were already in use for your value-based modifier. Those reports that you were getting, that's all determined by your HCC score. This is what determines your cost category under MACRA. So, you know, we know that they've proposed to have the cost category at 0 for 2018 again, but the reason they're doing that is they're saying they're giving us time to get used to how to report for cost under MACRA, and this is HCC scoring. Again, it's going to be everything pulled off your claims, no additional reporting. And I want to take a moment here to talk about some new modifiers and groupers that are coming under MACRA. Okay, so let's talk about this. There's 3 new modifiers or groups as well that are coming under MACRA, and they're called care episode groups, patient condition groups, and then patient relationship categories. Okay, so all of these will be required on your claims beginning January 1st of 2018. I'm going to stop there again. Again, all of these will be required on your claims that have a professional service on them. Let me clarify that a little more, beginning January 1st of 2018. So let's talk about them in a little more detail. Patient relationship categories. These have been released that they will be modifiers expected on a claim, and what these are going to do is they're going to attribute cost back to the provider providing the care based on the relationship to the patient. And what that means is right now, under many of the value-based care programs, if you are in primary care, you get attributed that patient and you're responsible for the cost of that patient. And so if they go to see a specialist, you're responsible for the cost of that specialist because you're held accountable for that in your reporting. What CMS is doing with these modifiers is they are pushing that cost, that responsibility to the cost, to the provider providing the care, but what it's going to be, of course, never that easy. So let's again talk through an example. So a patient goes in to see their primary care provider, and the primary care provider says, gosh, your diabetes, we just can't get it under control. I need you to see an endocrinologist. When that claim is submitted for the primary care provider visit, you're going to append a modifier on that claim that says the patient relationship is to their primary care provider. Therefore, the primary care provider gets all of the cost for that care, or that episode of care. Okay? Then, patient goes to see the endocrinologist. That first visit with the endocrinologist, a modifier should be appended to that claim showing that that first visit, that endocrinologist is working based off of a referral from their primary care provider. Therefore, that first visit will go back, the cost associated with it will go back to that primary care provider, so they'll still be accountable for that cost. But let's say the patient sees that endocrinologist and he says, oh, I need to see you every 6 weeks to get that diabetes under control. Those subsequent visits, a different modifier would need to be appended to that to show that the relationship now to the specialist is that that specialist is taking over care for a specialized diagnosis. Therefore, that specialist would now be accountable for the cost of care for that patient, for that diagnosis. Okay? These modifiers, again, are going to be required on every claim beginning January 1st of 2018. There hasn't been a lot of talk about this from CMS, but the one answer we've got a definitive yes or no on is we ask the question, will there be denials on January 1st of 2018 if these aren't included? And that was a very definitive yes. You will have denials on your claims if you do not have these modifiers on your claims beginning January 1st of 2018. Okay? So let's talk about the cost episode groups. Right now, again, if you reported to PQRS and you reviewed your QRUR report, you probably saw at the top where CMS indicated how much cost it costs them, or the cost of care for certain diagnoses. And CMS was doing this all on the backside through technology and formulas, and they were really looking for triggers to start tracking costs when it was an acute episode and when to stop when it wasn't an acute episode. Now what they're doing is they're going to move that to the front. So our understanding is this will be done through HCPCS codes. where you will have to put a code on the claim to notify CMS when to start tracking cost of an acute episode. So let's say the patient has CHF and they go into an acute episode for their CHF, you're going to need to have a HCPCS on that claim to show CMS when to start tracking, and again, when to stop tracking when that patient is no longer considered acute. This will help CMS to start tracking those diagnoses and the cost of care more accurately, and will help them to provide reports back to physicians on which diagnoses are causing the highest cost of care, and help them to start tracking improvements in those areas. So this is the verbiage right from the MACRA final rule. Just wanted to include it in case you wanted to read through all of that, but I'm not going to go through that word by word. On top of it, we have episode groups. So episode groups are very similar to HCC scores, and this is where CMS is going to take that cost and they're going to risk adjust it based off of the other patient conditions that that patient may have, knowing that certain conditions are going to accentuate certain diagnoses and the cost needed to care for that patient. We haven't gotten a lot of information on any of these, but we wanted to bring these to your attention so that you're aware and you're watching, because we are certain this is going to take a lot of education in organizations to be prepared for this. The timelines of these, the final patient relation categories and codes have been published. Basically what's out there is they had the proposed rule and they just finalized it. So those modifiers are out there. The care episode and patient condition groups, the proposed codes are out and published on CMS, and those are to be finalized on December 14th of 2017. And again, all of them will be required on claims with any physician service on beginning January 1st of 2018. So as you think about this, some things to consider is you may need to look at your billing system to make sure it can handle these new modifiers and codes. Work with your clearinghouses so they don't scrub them back off and recognize them as valid. It will take provider education, so they're documenting, so you understand those relationships and when to utilize them. And it's going to take coder education to apply these modifiers and codes as well. So where does risk adjustment fit in? This is all tracking cost, and all of those modifiers communicate cost and accountability for it to CMS, and it's all going to be risk adjusted again by the complexity of care associated with the HCC score. Okay? So how do you operationalize HCC scoring in your organization? What we have found in working with organizations on this is really it's bringing everyone together. This isn't a coding issue. This isn't a physician issue. This isn't a leadership issue. This is an everyone issue. This is bringing everyone to the table and understanding how it all comes together. Many times as we've had conversations with physicians and clinicians, we'll start talking about coding regulations, and they aren't aware of what you can code and what you can't and where you can pull information. So it's important to help everyone understand their roles and how they can impact this. Understand the common errors. These are going to be kind of your low-hanging fruit. Not documenting and coding to the highest specificity is probably the biggest. Again, if you look at pneumonia compared to aspiration pneumonia, big difference. Chronic or coexisting conditions not documented. We're leaving them out. We're not, many times I'm going to make the assumption, but if a patient with COPD comes in and they've got pneumonia, I'm thinking that clinician's thinking about that patient has COPD when they treat them. But if we're not documenting it, we can't let CMS know that patient has COPD, and that's what's driving the treatment plan. Using history of when documenting rather than stable. So I had an interesting comment when I was talking with some physicians about this. And the physician told me that, if I'm not treating them for that problem today, even though they probably still have it, they're not actively being treated today, it's a history of. So if they're CHF, I'm not making any medication changes, they're stable that day, it's a history of because I'm not treating them. Well, be careful, because Is it really a history of, or is it cured? Is it no longer relevant to their active treatment plan, or is it stable because of what's going on with them and their treatment plan they're on? Those are two very different meanings. And history of conditions do not have HCC scores. Stable conditions do. So it's understanding when it's appropriate to use both. And then again, it's the lack of understanding of how diagnosis coding affects your E&M levels. And we're going to talk about that in more detail. But first, I want to talk about some common errors so that we see as we're working with organizations. So for instance, a major depressive disorder does not have an HCC score. But documenting if that is a mild, moderate, or severe depressive disorder does have an HCC score. Obesity. Many times what we see is our EHRs calculate BMIs, but if there's never documentation regarding obesity, it can't be coded. And obesity is one big one that's left off often. So any BMI greater than 40 does have an HCC score. This one's interesting to me. So again, you know, we're talking about, it's more than compliant documentation. It's understanding the coding regulations. So if a patient comes in and the provider talks about they have a history of a CVA, and then later on in the note talks about that they have left-sided weakness, it's appropriate to assign these codes, but there's no HCC score. If that provider would state a previous CVA, if appropriate, with residual left-sided weakness, if they are correlated, that does have an HCC score. So you can see where understanding each other's roles and what can be coded and what is an HCC score becomes important. So let's talk a little bit about documentation requirements, because we can't code it if it's not documented, and we need it documented completely. So a synonym that we often use, that's often used in the industry, is M.E.A.T. Monitor, evaluate, assess, and treat. This is what needs to be addressed in your documentation to be able to code that diagnosis. Okay? It's important that providers understand that they should and are required to document all conditions that they evaluate during that face-to-face visit. So if that patient comes in for a sore throat, but they need a refill of their lisinopril for their high blood pressure while they're in there, if you assess their blood pressure, it's stable, and you decide to refill that lisinopril, you have your M.E.A.T. documentation. You've addressed that condition during the face-to-face visit. It's appropriate to document it. There should be a causal relationship for chronic conditions or manifestations. And then remember again that each note should contain a history of present illness and the medical decision-making guidelines for E&M guidelines. Now, some common misconceptions that we hear from coders and clinicians: I don't want to put all those diagnosis codes on there because it'll elevate my E&M code. It'll cause my patient extra expense. I don't have time to discuss all these diagnoses with the patient. Or a common one that we hear is, I can only put the reason for visit on the claim. The only code we can put on there is the reason why that patient came in that day. Okay, these are common misconceptions that it's breaking down those barriers and helping them understand that that's not accurate. Now, it is a balancing act. Again, we're not advocating for overcoding, we're advocating for accurate coding. And you need to understand that. It's also important to understand that you can't just pull information forward every single time in the medical record. The OIG is watching for that. The OIG is, you know, watching for canned and cloned documentation closely. So we want to make sure that's not a practice. Now, also understanding that if a chronic condition is only assigned once for the calendar year, this could be a red flag for audits, because there are audits going on about this. And so it's important that this is an every episode of care process. Also, let's say we are gonna you know, rely on our annual wellness visits to get all of these documented. Well, what happens if that annual wellness visit is denied or lost? You've lost all those diagnosis codes. They will not be associated with the HCC score because it's a denied claim. So again, making sure we're documenting and coding everything that's relevant to that patient every time is important. And again, just, you know, some common areas, we can't code from the problem list. So you can't just list every diagnosis. It has to satisfy M.E.A.T. That's, again, a common misconception that we hear. And then, you know, understanding the rules that we can assign codes from the past medical history if it's pertinent. So just understanding these rules. And then examples of supported documentation from a past medical history, and again, how simple M.E.A.T can be, M.E.A.T can be satisfied. Hypertension, stable on current medications. That can satisfy the M.E.A.T, okay? So these are ways that it can be satisfied. So some things to keep in mind is to avoid those unspecified diagnoses. The more detail you can provide about a diagnosis will result in more specific code assignment. Simply stating the status of a diagnosis as acute, chronic, or acute on chronic changes the code assignment. Components of a diagnosis are critical for code assignment. So examples are type of pneumonia, what stage of chronic kidney disease, if there's peripheral neuropathy, if there's rheumatoid arthritis, is it seronegative, seropositive, things like that are very important. And then conflicting documentation should always be clarified. For example, chronic kidney disease stated as stage 3 and 4 should be clarified with the doctor to understand, or iron deficiency anemia versus acute blood loss anemia, UTI versus pyelonephritis. If there's conflicting documentation in a chart on an audit, oftentimes the diagnosis is removed or downcoded, okay? And then also documenting sequelae of conditions. So document clearly if diagnosis is active or truly a history of, and then understanding to document the sequelae of conditions and make that causal link as well. So like hemiparesis is coded differently than hemiparesis secondary to previous CVA. Things of that nature. It's important to make those causal links. So as we think of, again, operationalizing HCC scores, some things you may want to consider is implementing a QA program. This is a way to make this part of an every encounter process. So it allows for continued education, keeping this at the forefront. It maintains that focus and allows you to identify trends so that you can really support and foster the education you provide your clinicians and coders as well. You may look at pre-appointment chart scrubbing. This helps maintain problem lists, and even though you can't code from problem lists, that helps key in providers of what they're looking for and helps them, you know, identify the most specific diagnosis. Many times as we're doing coding audits, what we'll see is we've referred the patient to a specialist and we get a beautiful report back from the specialist where the specialist has given us a more specified diagnosis based off of their expertise, but that problem list at the primary care doctor is not updated with that specified diagnosis. And so they continue to use the lower diagnosis code over and over again because they're not utilizing the information from the specialist. Pre-appointment chart scrubbing also allows increased communication. So they're looking at the chart. Maybe it is a patient coming in with pneumonia. You have that communication that, hey, you know, just a thought, is the COPD going to be important or relevant in this? You know, just a thought, do you need anything from us to make sure we've got that covered, or, you know, what's going on so we can get that documented if it's relevant. And then again, this is a great time to look and see if that patient is due for any preventative services. Preventative services are a nice time to bring in those patients and have lengthy conversations and have that conversation about their chronic diagnoses or screen for chronic illnesses as well to get ahead of them. It keeps our patients healthier and also, again, communicates to CMS the complexity of care that they need. And of course, we all have additional resources and tools at our fingertips, and so talking about more probably seems overwhelming right now. But there are tools, there are software programs that can key you in on what diagnosis is an HCC score and which one's not. We always stop and caution you though. Those tools are only as good as the operational process that you have behind it. So again, only picking a diagnosis because it's an HCC score, but if you don't have the documentation to support it, that will cause issues for you with audits. So let's talk about those audits. We're all used to RAC audits. Now for HCC scores, there's things called RADV audits, and they're risk adjustment data validation audits. So these are set up just like RAC audits. It's contractors who are contracted to review records, and they can be reviewed as often as annually, and they can verify that each diagnosis that has been submitted is supported by the documentation. And if it's not, they can remove it from the claim, which removes it from the HCC score. So it is the organization's responsibility to submit the medical records to validate that diagnosis and to support the use of that diagnosis in your coding. So there's 5 steps that an auditor will go through. They will request the documentation. They'll ask for a sample documentation selection. They'll do the documentation review, then a medical record review where they'll review the entire record. They'll estimate the payment error calculation, and then you do have the option to go through an appeals process. Now there's 2 different types as well of RADV audits. So there's a comprehensive, which they can just say, I want to look at these 50 patients. And those 50 patients may not be interrelated at all. They just randomly chosen 50 Medicare patients and they want to look at those. And then there's condition-specific audits where they may reach out and say, we want to review these 50 patients that have CHF. So it can be either or, and both can happen within the same year. So what CMS has found is they've declared that there is an error rate of approximately 33% with these. So they're finding a lot of errors, and again, that means they recoup payments and reimbursement based off these HCC scores. So it's important. Now, you can, if they ask for verification of a certain diagnosis, you can submit up to 5 dates of service that support that diagnosis code. So again, only submitting it once in a year is a red flag for these audits. If you have a lot of patients that have COPD and you're only submitting it once a year, but yet they're coming in for pneumonia and they're coming in for respiratory issues, and we're not putting COPD on those claims, that's a red flag for these audits. So be aware of that. Again, anything that's interrelated, we should be addressing in our documentation and coding. And then remember, again, January 1st, the slate is wiped clean. That, can't say it enough. That is very important. And then the work you do this year determines your funding for next year. So what that means is the claims that were submitted in 2016 built the HCC score that told CMS the expected cost and resource use for that patient in 2017. So you don't get the chance to update it throughout the year for the current year. You're always a year behind. So again, what you're submitting now in 2017 will affect what the expected cost and resource use is in 2018. Okay, so it's always a year behind. So let's bring it all back together. I've talked about a lot of information, kind of went fast through a lot of it, but it's a lot to get through, and wanted to make sure I was leaving time for questions. So again, as you're looking to implement this in your organization, it's like any change, any operational change, you have to understand it. You have to understand everything that's related, everything that comes together, and then educate. Bring everyone together, talk it through together, implement, get your QA program if that's what you decide to do, have your scorecards, have those monthly meetings, however that looks for your organization. Monitor, continue that continuous improvement, and then continue going around the circle. All right, Angela, I think we're ready for questions.
Great, thank you, Rhonda. So the first question in our queue, and this one goes back to when you had a fictitious patient and you were sharing examples of HCC scoring, and you had the poor coding, better coding, complete coding. So this question came from that time, and it said, how does CMS know if the patient is institutionalized? So I don't know if you want to go back to that slide or if that's enough to remind you.
Yep, I'll go back to it just to show everyone. Let me scroll up to it here. Sorry, I took away the slide deck for just a second. All right, can you see it again, Angela?
Mm-hmm. Yep.
Perfect. Okay, oh, and that's the wrong one anyways. Boy, I'm really hitting hard here. So how CMS will know that is by the common working files. Now, they'll know that they're institutionalized or live in the community by your discharge statuses. Their age, their reason for enrollment, that all comes from the common working file. But it's very important to have your discharge status updated. Rather, we see a lot, everyone's discharged to home, and that may be accurate, but it may not be as well. So make sure that you're utilizing the appropriate discharge status.
Great, thank you. Okay, so the next question says, where do we find the modifiers?
Yeah, there is a document on CMS website. If you just type in the search engine, patient relationship, you'll get the document that shows those modifiers. There's 4, if I'm remembering correctly right now, so it's not a long list of modifiers. But what we know is the organizations who do this well will be able to accurately reflect the cost associated with the patient. The organizations who don't do this well will end up receiving a lot of cost back to their organization that really they're not accountable for. So that's the patient relationship ones. The episode-based, there is a zip file out there. And again, if you search CMS and just put in episode-based groups, you will get that. And that also has the patient condition groups in it the last time I saw.
Okay, thank you. Let me see here. So the next question says, as we begin increasing the emphasis on HCC scoring for our organization, what do you suggest are appropriate first steps?
Yeah, you know, the hard part is it's hard to increase the emphasis if you don't know where you're at right now. So really doing a review of some records, looking at some episodes of care and looking for opportunities, and then utilizing those to provide education becomes very important, because then it's real. You can do a lot of general education to your staff and your teams, but when you use the data from your organization and from your records, it becomes real, like, oh yeah, okay, that makes sense. So it's important to do that. Of course, we, many times would want to use blinded data, but it's still your data. Many times, if you just do a general education session, you'll hear comments like, oh, but that doesn't apply to us, or, oh, I never do that. So again, when you take that time to really go through the records that you have, that's where we see the biggest bang for the buck.
Great, thank you. All right, next question. Isn't HCC scoring the same as a focus on compliant coding and documentation?
Yeah. So they're very related. Of course, it has to be compliant. We need documentation to support the coding that we do. We need accurate documentation and for it to be clear. But like using that example of the CVA with the weakness, the patient, if that was documented again, that it was, a CVA, and then later in the record they talk about the weakness, assigning those codes is absolutely appropriate. That would be compliant. I'm going to go to that slide if you give me just a moment. Again, assigning Z8673, the history of CVA, would be appropriate because that's what the documentation supports. That's compliant. And same with the weakness. But understanding that it's a step beyond compliance and having that conversation. So maybe if that was communicated through the documentation, it's a coder, querying back to that provider, hey, is that weakness due to the CVA? If it is, if they can, update or reflect that, well, then now you can utilize I-693-54, and that is an HCC score. So it's a step beyond compliant documentation. It's still compliant, and you still have to have the documentation to support your coding, but it's understanding all the rules and regulations with it.
Thanks, Rhonda. And I think this question goes back to the previous question. Could you send those links to Angie and she can forward to the attendees? So is that the modifier link?
Yeah, absolutely, Angie. I can send those to you.
Okay, great. And then I'll get those sent out to everyone. Thanks.
Yep.
Okay, I'm looking through our chat in our questions area, and let's give it another couple minutes for questions. I don't see any at this moment, but please feel free. You can still type them in. I will, while we're waiting to see if there are any more questions, I'll just direct you to the chat. And there's a link in the chat there. It says participants of this live coding webinar session can complete the evaluation and continuing education credit request link there. And so that's how I will know to send you a certificate. You'll indicate which type you want and who I need to send it to. So that's my cue to do that. So you must complete that to cue me to send you a certificate, and I'll be sending those out next week. So it'll be a little bit later next week that you can expect to see those in your email. So let's see, another question has come in. Is there a spot to see what the HCC scores are?
Yeah, so if you're part of an ACO, you get quarterly reports that have attribution reports, and you will see HCC scores on those on there from CMS. Unfortunately, there's not like where you can go onto a CMS website or onto the common working file and see what an HCC score is for that patient. With a proper QA program, you can calculate that score yourself to see where you're at approximately. But unfortunately, to actually see the data from CMS, it's not readily available.
Okay, how about for DX?
How about for what?
DX.
ZX?
DX. It's HCC scores for diagnoses, DX.
Oh, okay. And again, you can't, there's no place to review those as well on CMS. You can calculate them yourself based off of your data and your claims, but CMS doesn't readily publish those. There is a CMS document out there that will tell you the weights for every diagnosis. They won't tell you at the patient level, of course, but there is a document out there that will show you the weights associated with each diagnosis, though, and that may be helpful to help you calculate. And again, Angie, I can send you the link to that too.
Great, thank you.
Mm-hmm.
Okay, Rhonda, maybe if you want to pass it back over to me, I can put our last slide up and see. We've still got time for questions if folks have any. Let me see here. Okay, another question. Where can we see the links Rhonda is passing along? So I'll send those out through the email to everyone on this list here. So you'll get both of those sets of links that Rhonda will share with us. Thank you. Well, Rhonda, this has been a great overview for us, so we thank you and we surely appreciate your time and expertise and examples that you're sharing with us today. Thank you so much.
Thank you, Angie, for this opportunity. It was nice visiting with everyone today.
Great to have you all on. You have my contact information. If anyone has any follow-up questions, please let me know, and thanks again for joining us today. Bye-bye.
Bye.